Welcome.
Yeah.
Hello, hello, hello. Welcome. There's Kathy. Hello, Lucky.
Tell us where you are when you enter the webinar. Tell us who you are and where you are. Use the chat column.
Hello, Zikona. Hello, Yolanda. Please tell us where you are, who you are, what you're hoping to find today. Just chat with us. Hey, TBH, IVK. George. David, always wonderful to see you, sir. Welcome.
Yeah, they're folk from all over, hey?
Some regulars, Steve.
Yeah.
Our little family.
Particularly to newcomers, welcome.
Hi, Amanda. It's wonderful to have you. One of our very close friends, TVH IVK. I don't know, Steve, should we start just warming everybody up, or should we give it a few more moments?
I think let's start.
Yeah, so where are you today, Steve?
I'm in Geneva.
Showing off much. How's the weather up there?
No, lovely to see you, Goodman, and to see all our colleagues in South Africa and beyond. What would you say, Goodman? Do you want to introduce yourself first?
Sure. It's my pleasure to be joined by yourself and Bill and other panelists who Amy will introduce shortly. I'm Goodman. I'm head of addiction psychiatry at University of Cape Town and director of the International Technology Transfer Center down here in South Africa. And one of the things we really love doing is sharing the journey of MI with folks across South Africa, the continent, and beyond. So this project has really been a labor of love for us, and we are excited to have people continue to want to join us and have these conversations. I don't know if you want to tell people who you are, Steve.
I'm Steve Rollnick, and I come originally from Cape Town, and I live in the United Kingdom, and I'm sitting in Geneva, clinical psychologist, and together with Bill Miller, who you'll see on the screen here, we have gone on a journey with motivational interviewing that has now taken us into this webinar and into the question that we are addressing in this webinar, in this series of webinars, which is how can we improve practice out there on the African continent and beyond, informed by MI. So that's the general aim of this webinar series, is to create a network of people with a shared interest in this. And there I see Bill. Why don't you say hello and tell us where you are, Bill?
I'm at home in Albuquerque, New Mexico, and very happy to see this happening. I'm just here to learn what's happening in Africa and see what we can do to facilitate that.
Thank you, Bill and Steve. For me, the beauty of this product is the handshake it has with the rest of what we can do for mental health and public health, is that it doesn't argue with other interventions. And our contributors today will talk about how they've used that ability to create synergy with other components to develop curricula. And so it's going to be super exciting to hear what their thought processes have been and what they've learned and how we take it forward, Steve.
Yeah, and I took a look at the word curriculum, and you know, its origin is in the word race. I don't mean like a running race. That's the origin of the word curriculum. And it's a kind of a funny word. And I don't like it because we're not talking about a kind of a race that people are going on. And a curriculum is often something that where things are done to or on people, because this is the curriculum and this is what you'll do. So I prefer to think about the topic today as being like on the subject of a learning program or a learning journey for people. Anyway, that was just an open thought.
You could say symposium, which means to drink together.
Yeah, exactly.
That sounds like a good way to, because we're at the end of the day here on the continent, so that sounds like well-timed. I think, you know, Steve, you're talking about changing the language, isn't it? And that's kind of really what Emma's trying to do. So we'll see how our contributors have used the tools of MI to change the language when they do symposia to try and capacitate folks to better practice public health oriented communication, you know.
And we've also got some wonderful people in Cape Town, Lorraine, Fergus, and Shahima. Let's hope we can make space for them to contribute as well, because I know they, on the subject of curriculum, if you like, and how people learn and what it takes to like fire people up to learn, well, they've got lots to contribute. So let's hope we can find a way. But welcome to the three of you.
Absolutely. So to everyone watching us, you're going to hear some stuff from Fergus, Lorraine, and Shahima, as well as Amy. And on that note, Amy, we're in your hands. Take us through.
Okay, thank you. Thank you, Profs Rollnick and Sibeko. I think we'll mix between formal and informal. Thank you, Stephen Goodman, for that warm welcome, and welcome again to everyone. Just a reminder to all that this is being recorded, and that the recordings will be made available to you. It'll be emailed to you actually, so that you can just peruse through it after the time as well. So we have 3 guest speakers with us this afternoon. First, we will be hearing from Professor Ola from Lagos, Nigeria. Prof, you are welcome to start sharing your slides. If you can just put those up. You can screen share, or would you prefer that we do that?
Yes, I would prefer that you share for me. It will help me a lot. Thanks.
No problem. Angela, would you? Okay. So let me just formally introduce Prof. Ola, if I can get a look at my slides. So we are very, very excited to have Prof. Ola with us. He is a professor of psychiatry in Lagos State College of Medicine in Lagos, Nigeria. He's a Hubert Humphrey Fellow, which is a Fulbright program. He's a curriculum developer in addiction for the Faculty of Psychiatry in National Postgraduate Medical College and West African College of Physicians. Also a curriculum developer for International Consortium of Universities in Drug Demand Reduction, otherwise known as ICU-DDR. He's the country coordinator for ICU-DDR. He's also the UNODC Global Trainer in DDR. He's an associate editor in Frontiers Addiction, the Journal of Psychosomatic Research, and the Journal of Child and Adolescent Mental Health. He's also the editor-in-chief of the Nigerian Journal of Psychiatry. So we are quite honored to have him with us today. He has a long list of qualifications that he has seemingly accumulated from all over the world, from across the globe. Prof, welcome, and thank you so much for accepting our invitation. We are very happy to have you here and excited to hear from you.
Thank you very much, Amy, for the warm introduction. It's very exciting to be among you, and it's just about telling you a bit of my journey and also to share the experiences of learning with everyone. And I'm just going to talk about some of the insights I've gained from the development of a learning journey in addiction in my country, which is Nigeria. And I think the next two slides would show where Nigeria is. If you can just move to the next two slides. The next one, please. So Nigeria is just located in Central Africa, and it's a very populous country, about 250 million people. And that's just, and it's very rich in resources. But then there is a lot of problem with drug use in Nigeria. It's actually one of the corridors where drugs are also trafficked. But then that brings us to what we're talking about. If you can go to the next slide. Because it's a huge problem. The rates of use of psychoactive substances, it's more than what obtains globally. And these are some of the things that motivated others and myself to look into developing curriculum for addiction in Nigeria, particularly the training of non-specialists. And other things that motivated us was we were looking for how do we coordinate our response to the hydra head of addiction problems that is cutting across all the strata of the society. And we also found that there's a lot of gap in human workforce and resources, and that if we don't address this gap, then the problem of drug use might just not go away. And then we wanted to develop multi-professionals who would be competent, not just having the knowledge and skills, but to have competencies in addressing the current problems of drug use and the future problems of drug use. And there was a melting point where this food was developed, and it was in one of the meetings where the International Consortium of Universities in Drug Demand Reduction, where we all met. It was in Nairobi, Kenya at first, and then later on in Addis Ababa in Ethiopia, where we decided that there is a need to actually develop a workforce, particularly among non-specialists in addiction, because we have less than 250 psychiatrists for a population of 250 million Nigerians. And if you look at the rate of use of drug in Nigeria, which is sometimes approaching 35 to 40%, and then you would see that, I mean, that workforce is not enough. So let's go to the next slide, please. So, so we decided that within that curriculum, because we have found that a lot of studies internationally, I mean, well-conducted studies have talked about the effectiveness and efficacy of motivational interview. Even some of the local studies that I conducted, particularly using screening, brief intervention, and referral to treatment, actually addressed that problem. And then I also found out from my in-depth interviews and focus group discussions that among professionals in addiction in Nigeria who found that MI was actually very, very useful. And so we decided to accommodate the MI into the curriculum development for non-specialists in addiction in Nigeria, particularly in the area of knowledge, skills, and competencies. And the group of developers in this work, really, we comprised of people that were chosen from the 6 geopolitical zones of Nigeria, and they are from different disciplines: psychiatry, psychology, social work. And there was one person from the agency established by the country to address the drug demand reduction, which is the National Drug Law Enforcement Agency. And there was also a person from the NGO that was part of us. And we belong to different varying age groups, 30 to 40, 40 to 50, and there was one person who was above 60. And then we had different competencies in curriculum development. Some of us had certification in medical education, some in curriculum development, and there are I think a higher proportion who had field experience in developing curriculum. And so this constituted this group for the development of curriculum in addiction for non-specialists. So the next slide, please. And so the process actually that we engaged in developing these modules of learning to understand addiction and to be able to help to address the current and possible future problems in addiction, it's to actually identify and engage with stakeholders in addiction, because this is very, very key. And we use that to identify what are the problems, what are the range of skills, knowledge, and competencies that will be needed by the non-specialists to boost the workforce against addiction. And then we also looked at what would be the needs of these people. Particularly, we found out that most of the people that would be interested in this course, various range of courses in the universities, might actually be the people who are already at work. And so we needed to identify the range of hours that would be needed for their training. And then we went on to do what we call concept mapping to be able to identify what are the international best practices for programs in addiction all over the world, and the one that would actually fit low and middle income country. And then we took into consideration what we call the model of professional growth, which is actually what will facilitate adult learning with regards to change in knowledge, belief, and attitudes, and change in professional experimentation, and what would also facilitate collaborative process. And these are all the spirits of MI, really. And so we were able to see from all that method the components of the curriculum that we published. And this consisted of a range of knowledge, skills, and competencies and attitudes in the different aspects of addiction, including the biological aspect, the psychological aspect, and the sociocultural aspect, which are very key. And then we actually took cognizance of skills development, which would include MI, and which we found that it's a key concept in trying to form partnership with anybody that would include people who have problems with addiction, to be able to move and change and have different motivation for a lifestyle change. And so we decided to have courses that will range from short courses, diploma, masters, and doctoral, as well as courses that would integrate addiction within the program. And the focus would be either prevention, treatment, or a combination of prevention and treatment. And like I said, the target audience are multi-professionals across the healthcare. So we go to the next slide. And we found out during the process that monitoring and evaluation is very important, and that within the curriculum, we need to identify what will be the key performance indicators for the activities within the curriculum, for us to be able to monitor whether those activities are being carried out and are being carried out appropriately, and along with the time, and also to see what the evaluation would be, process evaluation as well as the summative evaluation, which will consist of what are the short-term outcomes, the medium-term outcomes, and the impact for the society. And within this, we found out that we needed to actually note the relevance of the concepts, the inputs, the processes, and the products, which would actually be some of the key products of the curriculum. So we go to the next slide. And when we finished with this, we found out that a lot of people who are professionals, who are in the university system, read and found out that they actually do not have what it takes to mount a program in addiction across the universities. And we decided to involve our colleagues throughout Africa. So what we did was to have a survey of these academics, and this survey revealed gaps that we use as the basis of developing an online curriculum to teach them how to develop a course in addiction, which we called Developing Drug Remand Reduction Programs in Universities, a Practical Guide. There is a link there, which you, if you are interested to see. And what we found out was that depending on, let's go to the next slide. That this new course, it's actually consisting of 7 modules, and these are very key. And the first module is about how do you get feedback from the market and the users in the field and stakeholders about what is necessary for an academic program development or a review in your country or within your society. And it is from that you'll be able to identify what will be the goals and objectives. And then you need to align these goals and objectives with the university goals and objectives. And so we had a module on that. And there is also the next module that talks about how do we determine the nature of the program that you want to develop in addiction, for what target population and at what level, and what would be the mode of study. Would it be online? Would it be hybrid? Would it be physical? And that addresses that. Then the next one is about the courses and the course content that you would develop. And this has to be aligned to the learning outcomes. And what we found out was that these learning outcomes, we find out a lot of universities would have learning objectives, but learning outcomes are centered on the learners. And this is very key, so that we'll be able to have a program that addresses the needs of the student and as well as the society. And then we moved on to the module 5 that talks about what are the requirements of regulatory bodies, what are the requirements of statutory bodies that actually govern the program development in universities, and that we need to be responsive to that. Then the next one was basically about how do you mobilize resources, particularly in countries in Africa that have low resources. And this is also key, and it's something important because I see a lot of people here, and how do we mobilize resources for program development and implementation. And this is hinging on the effectiveness of actually MI, because this is where what this symposium, using the words of Bill, is concerned about. And then the last but not the least module is monitoring and evaluation that I've talked about, which is very important, that it's a guide and allows you to know whether you are reaching your target and what are the things that you need to put in place if things are actually going wrong. And so what would be the implications for what I've been able to talk about? So that goes on in the next slide. And I have been able to see that there are implications for policy and practice. And we need to make policymakers aware and also sensitize them. They may be aware, but they may not want to move along, which is one of the spirit of MI. So the sensitization is about trying to see how they could move along. And these policymakers are in government, within the statutory bodies, universities, and professional bodies. How would they be able to be moved along in a way that they would develop the essential policies and pass these policies for the development of programs in addiction in our country and for other countries that may actually want to do that. And there are also implications for policy on the development of courses in addiction in line with standards, international standards. And then we found out that most of the people that would come into the program, there is no career course development for people in addiction in the service structure. And so there is a need for that in the scheme of service in Nigeria. And then we need to also ensure that there is policy for monitoring and evaluation. And the key thing we found out was that most monitoring and evaluation policies that are not well financed would actually not work. So there is a need for attendant budget. And then we have, very important, there must be a political goodwill for the development of this by the policymakers. Then for practice, really, the courses that are developed is not just for the ego of developing courses, but it's something that has to be responsive to the needs of the society. And there must be a practice in manpower development to address these needs. And then without this monitoring and evaluation within program and after programs, it is something that would let your ship get to the harbor safely. Thank you very much. I hope I've been able to stay within 10 minutes.
Thank you, Prof. You went a little over time, but it was time well spent. Thank you for that informative presentation. I think we already have a question. Goodman, was it your question? Would you like to? So we have some time now for Q&A. So you're very welcome to ask your questions. We have a few minutes before the next presentation.
Amy, before everybody comes on, I had a very quick question for Prof. Ola. In terms of how do you, for me, the paper was quite heavily based in the university space in terms of looking where curriculum is located. How do you provide for non-specialists in such a curriculum approach? I ask this being mindful that this was a fact-finding mission. So I wonder what your thoughts are, particularly in Nigeria. Because, if you're talking about capacity building in MI, for example, you have to think about the different levels that you pitch it, for example. So how does one locate this within a university-centric approach?
Yeah, thank you very much. There was, I think about 2-3 years ago, we had some courses from, it's called the Universal Treatment Curriculum and the Universal Prevention Curriculum. And a lot of people showed a lot of interest in actually learning this particular curriculum. And what was actually going on before then in Nigeria is that the domain of addiction is actually restricted in some ways to psychiatrists. And then it's a limitation in addressing the huge problem. So when it comes to different levels of non-specialists, we need to actually assess what would be their training needs, and then what would be the criteria for recruiting them, what would be the necessary qualifications that would ensure that they would be fed with what they need to know. And then we found out that we need to actually stem some of these things down to the knowledge that will be useful for different levels of people that would be interested. And then we found out that their approach, there's this theory of proximal zone development, scaffolding knowledge from known to non-known will be useful. And some of the experiences we gained was from those that attended, there is this motivational online course by one Professor Igor, and a lot of them actually appreciated it. And so it's not, we found out that some of these things are myths that people who are non-specialists may not be able to ascend to a particular level and get understanding and be able to use that to complete certain tasks, which we call skills, or to be able to complete these tasks with minimal or no error, that I would refer to as competency. So what I found out is that you need to be able to contextualize what you want and to do it within the, and it has to be student-centered. So it has to be centered on the needs of the non-specialists and how they would contribute to addressing these problems and giving them those things. I hope I've been able to answer your question. Thank you very much for an awesome question.
I don't see any other questions in the chat pane. Prof. Nash, would you like, you're welcome to go ahead and ask your question, Prof.
Yeah, no, I was just interested because you sort of tweaked my brain when you mentioned contextualizing things. But so I'm interested in, motivational interviewing. Of course, Steve and Bill have written all the books. But did you have to contextualize sort of the kind of motivational interviewing approach to make it work in Nigeria? Did you have to change things at all?
Yeah, thanks very much, Bob. Yeah, well, we've not got to that stage really. It's just about getting the curriculum and trying to find, because I think at the moment we have just one university, a private university that has started a course in addiction in Nigeria. Most other universities are in the process of still submitting the curriculum for the ratification of the university bodies. But then, like you said, there is it's from the field that you'll be able to know whether there is a need to contextualize. And I found out that the approach would be sensitive to the culture of the people that you are actually engaging with. And then, and I know that the spirit of MI is very responsive and sensitive to that in identify what would be, what is referred to generally as resistance. And so you need to roll with resistance in that approach. But then these are things that would actually be imputed into the curriculum. And this will also pan out in the practicum, and then what we have as feedbacks from that will be used to review the curriculum and actually be able to contextualize as we go on. So that's what I think we would be doing. Thanks very much. But it sets me thinking too.
Yeah, I've got lots of other questions now, but probably time is up.
Yeah.
Thank you. Thanks for that question, Bob. I'm actually thinking of Shahima and Fergus at this point. I don't mean to put you on the spot, but I know that you were involved in a presentation or a webinar not too long ago about how cross-culturally sensitive MI actually is. Am I correct in that? Is there something that you would like to add?
So I just wanted to make some comments on what Prof. Ola said before getting to your question. But I've got some experience, my team and I, we've trained some community healthcare workers in South Africa and in a rural SA as well as in the city centers. And it's quite interesting how that spirit of MI is the most important. And as you say, it goes across cultures, and just that empathy and working collaborative is what is universal. And so the only changes that I made with community healthcare workers, because they didn't have the academic backgrounds as a social worker or a psychologist, we created a lot of role plays and activities to build on those micro skills. And the only thing that I would still want to add is some Zulu or Xhosa videos to help with that practice. But what I found is that they take on to it very easily, and they're very excited to use this approach. Day one of the training is a little bit challenging because they still have to wrap their head around it, and it's a mind shift that they need to do, because in the communities, they are trained to tell the patients what they need to do to get to behavior change. So it's just telling them that it's okay to work alongside your patient, understand where they're coming from, using the spirit of MI, and then getting the patients or the clients to see for themselves the behavior change that needs to take place. So community healthcare workers play a very important role in our society, and they are quite important, and we need to get a lot of them on board with, even if they just grasp the spirit of MI, they don't have to know all the strategies, all the skills, they don't have to memorize the book. That spirit of MI is the thing that I think they take to very well. Okay, but I guess you would want to add, because you've trained so many people with me.
Yeah, thanks, Shima. I think I'd echo quite a lot what you say. I think one of the challenges that I've experienced maybe would just be the wording, that some of the wording words are difficult to grasp. Some of the words are difficult to grasp for anybody, like being able to operationalize compassion is something that's challenged because it's quite loaded, and people can often have a religious viewpoint around compassion. And then being able to then translate that with, community healthcare workers who speak Afrikaans or Zulu, that can be a challenge. And I think that would be a way forward in being able to find a language that might be more common. That's just my personal opinion, but I do think that the concepts are translatable and are easily taken on in the South African context.
And I just reminded, as you were speaking, that we even engaged them on asking them, so what did this translate to in your language? And get them kind of starting a conversation amongst themselves. And they usually land on a word within their language that could describe that skill or that strategy. So keeping it collaboratively always. I think Lauren has a hand up.
Oh, thanks so much, Shahima. I just wanted to also add that sometimes all we can do is shift the perspective from being very directive to guiding. So having this understanding that we're walking alongside our client, that there isn't this hierarchy, but that we're in this together, being with and for the patient in what is, that alone, that shift in the perception of a facilitative approach to communication that elicits behavior change as a result, that if we can make that fundamental shift in perspective, that makes such a huge difference in training.
Thanks for that. Thank you, Shahima, for this, Lorraine, those comments. I'm very aware of time, but we have some interesting questions in the chat, and I don't want to disrupt this clearly really interesting conversation. So Klaus, you have posted a wonderful question. I think you are allowed to unmute and go ahead and ask your question rather than me reading it out. Angela, would that be okay? Yes.
Go ahead, Klaus. Thank you so much, Angela. Thank you, Amy. Thank you, colleagues. It was just something that I grappled with just last week when we were at a CHC in the Cape Town Metro, where we also had some patients that were not literate, and we were just also afterwards, I mean, it's basically we're doing teaching on MI with fourth-year medical students, which is video recorded with the patient's consent, and then afterwards we reflect on the recordings together. And in the so it's actually the questions was from the students asking how to navigate it when a patient is not literate. And I mean, in our minds, seeing a scale of 1 to 10 is conceptually quite clear, but I think for many of our patients it is not the case. And is there, so we were comparing to maybe the pain scale or other scales, whether there's other ways of navigating that, just to gauge some where they are, because I think it makes such a difference to ask someone, but you rated your confidence as a 6 and not an 8. What would shift you? So how does one translate that in a MI consultation with someone who might not be literate in that way? And it's also more, not just is I'm also very mindful that it's probably quite a different worldview, or different to be culturally sensitive. That maybe that is not the only way to see the world in numbers. There may be other ways to grade experiences and confidence. Yeah, thank you.
Excellent point, Klaus. Prof. Ola, would you like to respond to that?
Yeah, thank you very much, Klaus. I think it's something that one would have to really think about, because I found out that there are certain concepts that are Western that are non-Western, particularly in Nigeria. For instance, when you talk about thinking, we would, in one particular culture, it's more about your stomach. And so we need to have what, like you referred to, what would be some equivalent concepts that are derivable from that culture. It may not be exact, but it might be some kind of approximation that can be useful. And this would depend on feedbacks that you get from people who are actually on the field. And when he talked about the different worldviews, yes, there are some cultures that may not focus on numbers, but what do they actually focus on, and how do we use that concept to make them to appreciate where they are actually going to? Because something that is universal is that we know where, I mean, there is, everybody understands what a journey is. Then how do you get to that destination? And so, and that's the aim. How do we accompany that person to that destination? So we may have to improvise by using concepts that are acceptable to people of that culture. I hope I've been able to address it in some ways. Thank you very much.
Absolutely. Excellent comments from you, Prof. Thank you so much. Like you say, how do we accompany our students, our patients on that journey? And what's so amazing about MI is that the underlying concepts are so universal. It's just about how we translate that to the people we engage with, so that we can all understand it in the same way, I think. Fergus, you had your hand up. Did you want to? And then I'm afraid we're going to need to end it there. I'm seeing comments and questions, and Shahima's hand is up.
Yeah, I think Shahima and I would have said the same thing, but we often spend some time developing a metaphor with the people that we train. So we ask them, you know, what might be good, what might be bad, and how we get the person moving from a space where they don't necessarily feel good about something to the journey to feeling a little bit better. So often, you know, the metaphor can be amount of cows, a road, like Prof Ola recommended, and a journey, and how do you progress further on the journey. And generally, we're able to evoke a suitable metaphor from the at least the community healthcare workers that's helpful for them.
Just add one thing. Our PG Div students one of them came up with an idea of colors, even where red is not so confident, not so ready, and green is maybe I'm ready for action. So you just have to be creative, I suppose, within the culture that you are working.
And again, I think what is so amazing about this intervention is that it allows for creativity and innovation. There is so much flexibility within the intervention, within the ideas, that just makes it so universal. So thank you again. I think we're going to round that off just there. I do see lots of comments and questions. I think we should move on to the next presentation. Prof Mash, you are welcome to prepare yours, please. I think Prof is probably going to share his screen. Are you comfortable with that, Prof? And then should we have time left over, we can easily come back and revisit this. So thank you so much for that discussion. So I'm going to go ahead introduce Prof Mash. He is no stranger to this community, at this forum. Prof, you're welcome to go to your next slide, because that's where I'm going to see your introduction. So Professor Bob Mash is a family physician working in primary healthcare in South Africa. He's the head of family medicine and primary care at Stellenbosch University. His interest is in lifestyle and behavior change, particularly with non-communicable diseases, which is something he's going to address with us today as well. He's an established researcher and editor-in-chief of the African Journal of Primary Healthcare and Family Medicine, and he's a trainer in motivational interviewing and brief behavior change counseling. We are very happy to have you present to us again today, Prof. Thank you so much for accepting the invitation. You may go ahead.
Okay, thank you, Amy. So I'm going to just chat for a few minutes about the group empowerment and training around diabetes that we've developed in South Africa. And I'm following the outline that I was given. So the first thing really is why is diabetes important? And it's now actually the leading killer of women in South Africa, and it's the second cause of mortality overall. No longer is HIV leading the show in South Africa, but it's now diabetes and TB. So in Cape Town, we actually just looked in our public sector database, and we found that we've got more than 100,000 people that we know of with diabetes attending primary care facilities in Cape Town. But unfortunately, our support for self-management has really historically been quite poor. And at least 2/3 of these people are uncontrolled. In fact, 1/3 of them are very uncontrolled, with all the sort of complications that entails, including, of course, COVID just recently. But many years ago now, actually about 10 years ago or so, the chronic care teams, the people in the primary care facilities, suggested that, with all these huge numbers, what we need is a group approach to educate and sort of motivate people around self-management of diabetes. And so that was sort of set us off on this journey. So we looked, of course, at motivational interviewing, and as you all are very aware, there are lots of behavior changes involved in self-management of diabetes, many of which I've listed here. There was also, even then, I think, a book published on group approaches to motivational interviewing, though it was quite sort of psychologically kind of orientated, but there was an evidence base for group MI, and there was also an evidence base for group approaches to helping people with diabetes. So we decided to follow this group approach, and we sort of took, it's not strictly speaking a sort of pure motivational interviewing, but we took elements from motivational interviewing. And I think, as somebody said earlier, the key thing for us was really sort of embodying a guiding style in the whole approach. And we defined the guiding style as having these 5 elements, which was quite a big shift from what people are normally doing in primary care. So being collaborative, that both people participate, as Loren said, on more of an equal playing field, being empathic in terms of understanding people's context and perspective, being evocative, obviously drawing out ideas and solutions from people, respecting their choice and control, but remaining purposeful in following, focusing on a particular change or behavior change. The developers of the intervention, this group intervention, apart from myself, we had Buyelwa, who is a local Xhosa speaking diabetes educator and a social scientist, and this person who is very well known to you, Profs Rollnick, who kind of came in as an expert in MI to kind of advise us on the design of the thing. And I like this ADDIE process. So in fact, we were almost developing two educational interventions here. Of course, we're developing an intervention for people with diabetes, and then we're having to develop another educational intervention to train the people who are going to deliver the intervention on diabetes. So, but this slide is about the actual thing that we did with the people with diabetes. And the ADDIE process stands for, analysis, design, development, implementation, and evaluation. And it's a really nice process to follow for the development of any sort of educational intervention. So our initial analysis, of course, was very much guided by these chronic care teams. And they actually didn't just say, follow a group process. They said, listen, there should be 4 sessions. And the 4 sessions should be on, what is diabetes, lifestyle change, understanding your medication, and avoiding complications. And they also said, by the way, us nurses are way too busy to do this. It should be a health promotion officer who delivers the intervention. So they gave us quite a lot of input. And then we also looked at similar initiatives such as the conversation map, which was a very helpful one. And then with the design stage, we did, as I've said, we particularly aligned ourselves with a guiding style and those sort of key principles. And then we selected key skills that needed to be embedded. And we selected key content. So the 4 sessions I've mentioned, and in fact, we then designed every session around the elicit provide elicit model, which is a particular skill around sort of exchanging information rather than transferring information. We took that actually as the overall design focus. So the whole session was built around getting something, as it were, from the participants, usually asking them what they already knew, what they wanted to know, giving a little bit of information, and then getting them to work with it, apply it to their lives, and try and work out what its significance was for them in terms of change. And then, of course, we developed a whole lot of different resource materials for the groups, for the facilitators, and for the patients. And so here is, some pictures of the groups and some of the materials that we developed. But I think what I really wanted to get onto was this slide, which is on our approach to curriculum development for the facilitators. So how did we go about training the health promotion officers to go and deliver this whole group process? And of course, the first thing, as others have said, is to understand that a health promotion officer is actually, in a sense, more or less a community health worker. They're lay people that have been trained to do health promotion in facilities. And so they've got very little background in health, and they've got very, very little background in sort of communication skills. So one has to tailor what we expect of them to that context. So that was the first thing. So we didn't really think we were able to train them completely in a sort of motivational interviewing approach. We had to distill out essential elements that we trained them in. And at the end of the day, we didn't just expect them to know things, we expected them to be competent to deliver these whole group sessions. So they had to do things, not just know things. And I think one of the first things in training these facilitators, as I say, we're mostly health promotion officers, we first of all had to connect with their own experience their own challenges and their own frustrations. A lot of these health promotion officers for years have been standing in front of queues of people waiting to get their folders and so on, sort of shouting at them about diabetes, and trying to do health education in the facilities. So the first thing, of course, was to connect with them, their experience, their ideas, get them to speak about the challenges and their experience of trying to do behavior change. And then I think we had 4 key ingredients in our curriculum design, and I think these for me are really important. So theory, modeling, practice with feedback, and embodiment. These are my sort of 4 trump cards. So the theory that we had to try and embed into the curriculum was actually around diabetes, because it's no good just being a good communicator. You actually have to know what you're talking about. So we had to embed the opportunities to improve their knowledge of diabetes and engage with experts. Then modeling. So the facilitators, the people running these training programs for these health promotion officers, of course, had to model everything that they had to do in these groups. And then they had to practice, and not just practice, but also get useful feedback from the people training them on how they were doing and how they could do better. And then finally, embodiment. So the people training these health promotion officers had to also embody the very things that they were trying to tell them about. So they had to embody a guiding style in the way that they trained the health promotion officers who were meant to go into groups with people with diabetes, and also embody a guiding style. And then I think the other key thing that we thought about was, what communication skills do these health promotion officers need? And we very much thought about it very simply in these 3 areas, these skills around asking, listening, and informing. So we targeted changing them from asking a lot of closed questions to open questions. We thought that getting them to a very high skill level with reflective listening was probably not possible in the time available, and we rather focused on simple summaries. And then with informing, we spent actually quite a lot of time on this elicit, provide, elicit structure, which was, as I say, the sort of foundational design element in the whole thing. And then, of course, it's no good just training health promotion officers in a nice venue and then send them back to the primary care facility, where, of course, they're one of the least powerful people in that facility. You've also got to think about the training practice gap. So what are all the organizational issues that you need to think about and address even during the training to ensure that they can actually go back to an environment and deliver on these new skills that they've learned. So we spent quite a bit of time trying to engage also with the facility and district managers, and to think through some of the issues around how will patient flow enable them to attend these group sessions, how will their appointment system fit in with this, and so on. So the space was a big issue. Where will this actually happen? And is there a space that's kind of conducive to this kind of group process? And then finally, of course, you have to then follow up, and we had to reinforce training after a few weeks or months, bring people back and do further training and reinforcement and hear how things have gone and so on. So I think this is my most important slide in terms of curriculum development. I was asked about what evaluations took place. I don't think I'm going to go through all this, but we've done a lot of evaluation of this thing, and there's a reasonably solid evidence base that it works in our context, including sort of important things like improvement in glycemic control and blood pressure, which of course are clinically relevant, and also that it's cost effective. And then the implications for practice. So I think we have argued, and I think it's been accepted, that this is an evidence-based intervention for people with diabetes, and it can be integrated into primary healthcare. We've largely focused on facility-based groups where we've mainly focused on people who are really badly controlled and extremely badly controlled, and the new patients. But of course, there is also potential for this to be done in communities by community health workers, in support groups and so on. The intervention, we have been trying to scale it up. We had funding to scale it up across the whole country over the last 2 years. Unfortunately, COVID-19 somewhat dampened that whole process. But we have actually trained now primary care providers in 6 of the 9 provinces in South Africa, and are busy evaluating the implementation of this in those provinces. And in fact, during COVID, as an aside project, we also developed a chatbot to deliver some of the educational content as well. But so 10 years later, we're still busy with implementing Great for Diabetes across South Africa. And I think we will now be still busy with it for the next 4 or 5 years as these provinces try to also go to scale within the provinces. But of course, our long-term goal is that this sort of motivational interviewing, group motivational interviewing for people with diabetes should be available in all primary care facilities in South Africa. Yeah, so that is my story, and those are the references if you're interested.
Thank you so much, Prof, for your presentation and for the in-depth focus on the curriculum. I think that was very, very useful. Thank you so much. We have quite a few questions and comments already. Prof Sibeko, I think you posted a question. Would you like to go ahead first? And then I've also noticed Amanda. Amanda, you can maybe follow Prof Sibeko. Goodman, you can go ahead, please.
Oh gosh, I hope it can be a brief question, Bob. I think my question was really, how did you select which skills to focus on? What did you base the selection on?
Sorry, the selection of?
The skills to focus on in the training.
Oh, the skills to focus on. Well, I think Steve actually was quite important here in deciding what to focus on and not to focus on. As I said, I think we needed to have something in all 3 areas, asking, listening, and informing, and we needed to have something that we felt health promotion officers could really become competent in a relatively short period of time, and given their sort of baseline and where they were coming from. I mean, actually, we actually looked at their fidelity to this, and what we found was, as Lorraine said earlier, is that they did shift from a very directive style to a guiding style. And this was actually sort of, I mean, it was fundamentally kind of like a game changer, you know, and I mean, and they also commented, you know, that patients seem to actually like talking to them now, you know, and actually kind of track them down in the corridors to ask them things. But they managed to get the questions, the open questions. They managed to get the illicit provided illicit. They partly managed to get the sort of more summaries and reflective listening. That was still something that they were working on, I think. And of course, we didn't really attempt to train them fully in sort of reflective listening statements and all the nuances of that. We really just wanted them to get the idea of listening and summarizing. Yeah, I don't know, Steve, whether you want to comment on that, or if you can remember why we chose those skills.
No, there was just a conversation between us, and we did what we thought might work in the setting.
Yeah, thank you. I think you answered the question quite adequately. I wanted to move on. Amanda, I see you've made a comment. Would you like to go ahead and unmute and then just share your thoughts? So if you have a question, you may go ahead.
Need to activate Amanda's sound. Go ahead, Amanda, if you're able to.
I'm able to, Angela. Thank you. Hi, everyone. Thank you for this great session. As you'll note that most of my discussions are really around comments. I think I'd just like to say one of the things that we have observed, particularly in the TB program, is that, the health programming is moving to a community-driven approach, where we are really trying to make sure that, we get the people at community level either to return back to care or to know about services, and also to make sure that they adhere and actually, they get to be cured of the disease. So one of the things that we've actually found, because we had one of our community healthcare worker groups where they are tasked with tracing clients who have interrupted treatment. And one of the issues that they would find is that either they would talk to the client in person, or they would talk to the client telephonically, but however, they wouldn't be able to persuade the client to return back to care. And I think that's where motivational interviewing came in. I think that's why my earlier comment was on the basis that we have always worked on the assumption that just because you're a healthcare worker, you're going to be able to convince every single person under any different circumstance to return to care. But however, motivational interviewing is giving a different aspect that says, actually, we need to build more capacity in how to talk to clients under different circumstances. And I loved how Prof talked about, creating a space around where they were able to share their experiences, and a recommendation to say that that could also be part of the case studies to include in the curriculum design, to say that in the classroom setting, this would be how it is, but talk to the person who has to go through this every single day, to go and talk to different households, different people every single day, and how all of this could be shaped. And of course, having it in different languages would also be most ideal, because we are dealing with different clients at different times. So it's just quite a very good session to be at. So thank you very much.
Thanks. I think one of the studies that we saw in Cape Town looking at barriers to behavior change counseling found that actually almost the biggest barrier was that healthcare workers sort of had given up in a way, because their experience was, we tell people what to do, repeatedly, they don't do it. And so therefore this whole thing is a bit of a waste of time, and I'm not going to do it in future. And of course, they're doing it in a very directive style and getting a lot of non-compliance back. So people actually were resistant to even doing it. So I think that's why one has to actually give people a space to kind of vent in a way their experience of trying to get people to change their behavior, in order to engage with them about alternative ways of doing it. I mean, Lorraine, you've experienced this a lot in training, haven't you? We always start our training with this sort of connection.
Yes, absolutely, Bob. And that really establishing that relationship with our participants first, and understanding their context and the challenges that they face as healthcare practitioners, and then meeting them from that place and building from there. So it makes all the difference. Really engaging.
Yeah, I must admit that I also really liked the idea of focusing on the learning outcomes and creating a reflective space, a space where people can just sit and think and share and learn from each other. I also had a particular question about your idea around embodiment. So there were particular outcomes or things that you were focusing on, Prof, and one of it was about the trainees embodying a guiding style. And I was really curious about how you promoted that, how you got people to get to that point.
Well, you see, I think it's and we see this not just with training in motivational interviewing, but training in other things as well, is that it's not enough to know the theory and communicate, the theory of motivational interviewing. If you've got to embody the thing in yourself, I mean, you have to, almost without thinking about it, kind of live and breathe a guiding style, in the way that you engage with people, particularly obviously in this case, in the training. And that's what I mean by embodiment. So, and that's maybe even more powerful, than any theory that you share. Yeah, so that's really what I was getting at. And so it means that your trainers have to be, very well trained. They have to be competent in the thing that they are training, and not just know the theory, having read it in a book or something. Yeah.
Absolutely. It's the same thing that I encourage students. So I talk about embodying it. I was just curious about how you encourage the trainees to do that. So we can talk about embody, and how.
Perhaps I can add on to.
Sorry, go on, Laura.
Yeah. I mean, Bob, us having trained for years together, there's a lot of real play, role play, modeling, learning through the group process. And then with the group, seeing when somebody's stepping ahead of the client, when they're being directive, actually experiencing what that feels like to be on the receiving end of that, and what it feels like to be met with somebody and engaged with. And so that they're experiencing both ends of that spectrum, when they're really feeling that wrestle, and when they're experiencing that dance, and the interplay between them both, and contrasting their experience of those different styles. So making it as experiential and as relevant to their specific practice context as possible.
Well, if I may add something, when Professor Ball was talking, because what we found out was that adult learning approach, it's quite different from the child learning approach. And so when you talked about the embodiment, it's actually something that reflects the Cobb's theory of experiential learning, which is actually good for people. And then the use of the word embodiment actually captures the essence of that. But what I would also like to add is that reflections are actually very key with people after the practicum. So I would have been interested in hearing what were the personal reflections of the people that were trained. And that's one thing that would actually be useful in adapting or revising the training package that you have been able to develop. But there's a bit of a distraction here because I had the audience of someone who was diabetic in Nigeria. It was, she's been told exactly what to do, and then she became suicidal. So it's not that I'm making the link, but then it's quite possible that telling people what to do could actually lead them to some kind of exclusion without you giving them the space to express themselves. And actually, when I talked with her on the phone, and it was just natural for me to kick into the spirit of MI, and it was very surprising to me for her to accompany me. I was now accompanying her in the journey, but out of the decision to take her life and to go back to try to adjust her lifestyle to be able to do things that she actually really wanted to do in life. Thank you very much.
I think the first part of what you said was really asking about sort of the reflections and feedback. When I talked about simulated practice with feedback, of course, I was more saying that that's more about watching somebody practice, the motivational interviewing or whatever adaptation like we had, and then giving them useful feedback. And of course, so that also means that actually the trainer needs to be skillful in giving feedback. And there actually are approaches to that. There are various approaches which are consistent with a guiding style. The Pendleton model, of course, in family medicine, we love that. And of course, you can also, in the group process, you can also get people to give each other feedback as well. But I think you were asking about reflections at the end of the training on the training itself and what we had learned from that. I'm going to ask Lorraine, who's been running training courses very recently, what sort of reflections do you get at the end on terms of the training and how it went and how to do even better?
I think that the biggest learning every time, Bob, is people come, healthcare workers. We've just run a group with pediatric dentistry, and the week before that with Department of Health registered counselors, is a real sense by the end of the workshop of being met and hopefully and understood, and a sense of cohesion and collaboration, not only with us as facilitators, but within the group. So really, that when there's a sense of I'm not learning the skill in isolation, but I'm developing a capacity in association with my peers, that I'm feeling supported as I'm internalizing this new skill, which can feel really itchy in the beginning. And I go through, and I often notice how participants go through their own resistance, for lack of a better word, and how we hold them through that to the best of our ability through reflecting that and being with them through that process. So often, the reflection is that there's a paradigm shift in them as they've internalized the skill and how they've felt held through the process. And I think that that's what you're referring to when you're speaking about embodiment, is that mirroring that's hopefully happening through the training process. Does that answer your question?
Well, that's very good, because I remember when I was in the US and I attended a clinic, there was a lady that just finished a motivational interview with a client, and she was fuming and said that at a point she felt that like dropping MI and telling this client that you had made mistakes. So when you were talking about reflections, I found that the graduate, it's a kind of lifestyle change that you are taking the people that are being trained through. And so if you rush them through the training, they might not be able to drop the baggages that they already come with. So, and that's why I felt that reflections, and these reflections are not for the end of the programs. I mean, just like when you're teaching, there is this formative assessment before you get to this summative assessment. So these reflections are something that should be ongoing, and they would see themselves growing, just like a snake shedding some of their old skins, and then doing. So that's just what I have. But I'm satisfied. Thank you very much.
Oh, thank you.
I mean, people come to the training, don't they, at very different places in sort of how distant they are from the guiding style and from motivational interviewing, and differ then considerably in how much of a journey they take during the training, and they don't all end up competent at the end of it. I don't know what our success rate is in sort of beginners competence around, but it's definitely not 100%.
No, 75% sometimes.
And my only other comment, Bola, would be that toxicity that you mentioned about the person with diabetes who was suicidal. I mean, I think a very, very strong directive style, which we see a lot in South Africa, can be toxic for the patient. It can also be toxic for the healthcare worker. A lot of them are carrying a lot of anger and frustration and sense of thwarted responsibility toward the people that they're trying to help, who seemingly don't want to be helped. And of course, that's also part of that initial conversation.
Thank you.
This conversation is reminding me of something that I heard Steve share before in a previous training, or not a webinar, a lecture, I think, Steve, years ago, where you said that people are probably mostly kind of naturally born with the ability to empathize. They're born with these abilities to connect and this guiding style of being, but it's unlearned through rigorous training. So if you think about the training that some of our colleagues go through. They are taught very seriously, rigorously, all day, every day. This is how you engage with your clients. This is how you engage with your patients. And then they come to
curriculum, though, isn't it, that they learn? Because we don't set out to train them that at sort of, or certainly not at medical school, but they learn the opposite through the hidden curriculum because that's what they actually see practice. And then they learn that because that's what real people do.
Yeah, that's a good point. Steve, I don't know if you want to add to that.
No, only that I think the link there from a child to an adult is curiosity. And one of the beautiful things about this webinar is that it's gathered quite a lot of wisdom about how to evoke curiosity in the people that you're working with from the comments of the various trainers who've contributed. So, but I think curiosity is such a powerful vehicle for helping folk to learn and practice better.
Coming from a position of not knowing, or rather placing yourself in a position of knowing to not knowing, coming into a session with a client, feeling very confident about what you know, and not so curious about what you don't know and what you don't understand. Goodman, you want to add?
Wondering, Steve, if we also want to say embodying that idea that the person receiving the intervention, which is MI-based, is the expert on their lives and on their resources. And in the same way, the person who's receiving the teaching is an expert on the tools that they need to move them forward in grasping the content. And so that if the training models MI, that should be a part of the interaction as well, as you guys are the experts on how you will learn all of this and how do we bring that into the training.
Beautifully put. I wonder if Bill Miller wants to add anything. He's been so quiet.
I'm just happy listening, and I mean the emphasis on the underlying spirit of the expertise of the person you're talking to, respect for their choice making. I mean that is so important, and I'm glad to hear it in so many different voices here.
Amy, if I might, one of the engagements I've had with Glenn Hines and team were about what are the real differences around capacity building and motivational interviewing in our context. And one of the things I suggested in my podcast with them was we serve a community that's not used to being recruited as experts. They're not used to being asked, what would you like to contribute to the decision making here? They're used to paternalism, being told this is what you have to do. So, Prof. Ola and Prof. Mash, when I listen to your approach of capacity building, that sort of rings at the back of my mind is, you don't have to answer, but it's something that I'm thinking about is how do we account when we're trying to impart MI skills in our context for folks who aren't used to having that power? So do you think that impacts on receptiveness? So do people who aren't used to being asked to contribute know how to contribute and be part of the process?
Yeah, I mean, I think because we also try and teach sort of shared decision making, in general in the consultation, and because there are decisions that people do struggle to participate in. But I mean, the kind of stuff that that we're talking about, which is somebody's own behavior and kind of how that shows up in their life, I don't think people have difficulty kind of engaging with that when they're given the opportunity to do so. But I do hear you. I mean, people are not used to even being given the space to participate in the conversation. They're so used to just being told things. But I think in this particular, I think with motivational interviewing, which is focused on how does one change one's own behavior, I think when people are given the opportunity, they definitely show up and participate. I think there are other types of decision-making that people struggled to participate in more?
Well, for I would talk about this with a kind of metaphor where you find eagles that are mingling with chickens, and the eagle doesn't know that it's an eagle, and it doesn't know how to fly until situations arise that makes the eagle to be able to spread its wings and know that it could actually fly higher than the chickens. So what I think there, because we have that paternalistic nature is being so socialized to people after being born, but the thing is to be patient with the client. And because I see some people that will say, well, doctor, it is whatever you tell me that I would do. But then you also have to allow them to say what are their wishes. And when you give them that space, it's like you reflected that Steve said that people are born with that. So that's natural ego instinct, if they are given the space, would naturally board. Because it's not killed, it's there. It's just that it's dormant. So if you give them the space with some patience, and because you are a friend, you are not even rushing them, then you will see that that would eventually develop. Thank you very much.
Wonderful, wonderful. I think it's such an interesting question that you've asked, Goodman, and it's just made me also think that I think it could also be a training opportunity. So an opportunity to help the trainees develop empathy, because that is the same position that our clients are in. So and both Prof. Mesh and Prof. Ola have said that our clients are often in this position of just, I'm just going to be told what to do and I'll go with it. And it's very different for them when they are invited to do something else. So if you are training trainees who are in that same position, like just teach me, you're the expert, and just tell me what to do. But when you invite them to be a part of that collaboration, I think it's an opportunity for them to develop empathy with the clients that they will eventually be working with. So, yeah, but I think it's also something that in training can be highlighted and reflected, and can just add to that idea of embodiment, I guess.
Wow, that was well said, Amy. Thanks so much. I can see you scanning the machine, and yet I'm aware that we're bang on time here now. But what a wonderful collection of observations today, and it's really is a treasure chest of wisdom here. Some of the words that came out of people's mouths, I couldn't believe it. So I'm so pleased we've got this recorded, and in itself, it can be a wonderful learning tool.
Absolutely, Steve. I never get used to how awesome these conversations are, and the audience's participation is always really stimulating. So we just want to really thank you all for being so engaged with us, and for warmly receiving what we've come to share with you. And we really hope you'll join us in future. Amy, we are in your hands, unless Steve or Bill have any additional closing comments.
Thank you. I actually just wanted to ask Bill if you had any final comments to add.
Was that me? Who were you asking? Bill.
Bill.
Bill. Okay. Sorry.
Bill. Yeah. I think we all have comments to add. But no, I'm just delighted to see this happening. I was interested in encouraging people in Africa who were experiencing and teaching and practicing MI to talk to each other and learn from each other. And that's exactly what's happening here. So I'm delighted.
Well, thank you all so much. I think Goodman, Steve, and Bill have said it all, really. I just want to specifically thank our panelists, our guest speakers, of course, as always, Bill and Steve. It's just absolutely amazing to be working with you and to have you in this forum. Really a wonderful and exciting opportunity for all of us. And thank you to everyone who's attended. It's been a good hour and a half spent with you. It's been fruitful, it's been productive, and it's been exciting. So thanks again, and keep your eye out for invitations for follow-up, whether it be webinar or in a different format, COVID depending. Okay, thanks so much, everyone. Thank you, Angela, for all of your support through this. Thanks. See you next time. Have a good evening or a good day. Hey, Bo and Steve.
Thank you. Bye.
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 Bye.